next and last session. I call upon the chairpersons of the session, Dr. Vaidyanathan R. Sir and Dr. Naresh Kumar P. Dr. Vaidyanathan Sir is a Chief Intensivist, Head Department of Anesthesia, Intensive Care and Pain, Kaveri Heart and Multispeciality Hospital, Mysore, and he is also the present Secretary, ISA Mysore City Branch. He is the peer reviewer for Indian Journal of Anesthesiology, editor, board member, JMEDS and RJAHS. Sir has more than 17 years of experience in corporate setup. His areas of interest include trauma, critical care, resuscitation and regionals. Sir has been an invited faculty and chaired sessions in many regional and national conferences in anesthesia and critical care. Sir has more than 15 publications in national and international index journals. He has conducted more than 150 BCLS and COLS workshops. He is an accredited teacher by National Board of Examination and Indian College of Critical Care Medicine to train postgraduates in anesthesia and postdoctoral fellows in critical care. Dr. Naresh Kumar did MD Anesthesiology in this institute, Mysore Medical College. Presently, he is the senior consultant in Department of Anesthesiology, Krishna Institute of Medical Sciences, Nellore, Andhra Pradesh. His areas of interest are obstetric anesthesia, regional anesthesia, and pain management. We welcome you, sir. Over to you.
Good afternoon, all of you. As we move on to the final session of SZISACON2023, for the pre-lunch session, just to keep us all awake, wide awake, and still active, forgetting our hunger pangs, we have the ideal speaker. With warm pleasure, I welcome Dr. Shishir Chandrasekhar, a hugely popular figure, consultant anesthesiologist at Sakra World Hospital. He did his postgraduate from Mysore Medical College and did his multiple fellowships in UK. His areas of interest include pediatric anesthesia, TIVA, and probably quality improvements in anesthesia. Over to you, Shishir, sir.
Thank you, Dr. Vaidya, for those generous words of welcome. It brings me great pleasure to stand where I trained, and today this talk I would like to dedicate to my teacher who taught me pediatric anesthesia, late Professor Dr. M.K. Radha, from whom I learned whatever little I know, and Professor Vishwanathan. And I see many of my teachers, or I hope to see many of my teachers here as the talk goes on. Thank you for this opportunity. So what I have been entrusted with is to speak on pediatric extubation with a emphasis that it might be more of an art than science. I'm sure it's well-intentioned, but the problem of elevating something to an art form kind of makes it seem like some people can do it and some people can't. And I think that's an entirely defensive way of looking at it. So I would kind of like to submit that all of us here are men and women of science, and we would like to think of scientific, reproducible ways of doing things. So, in fact, I would kind of contest this argument, although I know why it is said to be so. So, in this context, over the next 15 minutes or so, I will try and demystify extubation, which is a big problem for anyone doing pediatric anesthesia, as we all know. We will look at why extubation failures happen. We will also look at what treatment strategies are that we could adopt to avoid them from happening. And despite our best intentions, should it happen, how do we go about handling it? Ralph Vaughan termed extubation the Cinderella of anesthetic practice. It's the forgotten sister, the poor sister. A lot of emphasis gets placed on intubation and all the fancy gadgets and fancy technology to get a tube in, but we simply forget the fact that that same new tube needs to come out at some point. Complications, as all of us practicing anesthesiologists know, complications tend to happen much more at extubation than they do. Thrice as much you will have a problem at extubation than you are going to at intubation. It results in fairly innocuous respiratory phenomena, ranging from coughing and a bit of bucking, which can quite quickly progress to bronchospasm, laryngospasm, hypoxia, and dreaded laryngospasm. Cardiovascularly, it is not innocent either. You could see either tachycardias or bradycardias. You could see hypertension, hypotension, and a lot of problems as a consequence. In addition, we know anybody doing clinical anesthesia, it's not without its problems. All this coughing and bucking can raise intracranial pressures, cause intracranial bleeds. It can, mess up with the surgical field. It can cause wound dehiscence, pretty sharpish immediately after surgery. And again, in the context of COVID, it is a massively aerosol generating procedure. It generates as much aerosol, 15 times as much as an intubation would. What about in pediatrics? The apricot study is something those doing kids might be aware of. It's a large study of over 33 European countries, 260 units doing regular pediatric anesthesia. And there they came up with this number that 1.2% of kids actually end up with laryngospasm. This is in tertiary pediatric facilities in a European context where there's no dearth of clinical material, or teaching or equipment. And laryngospasms, if you look at a close claims analysis in the US, it contributes up to 6% of all cardiorespiratory arrests that happen in kids. And this incidence could be as high of laryngospasm, could be as high as 1 in 4 in kids undergoing T's and A's, tonsillectomies and adenoidectomies. So it is a real problem and needs real solutions. So how do you plan a safe extubation? So a lot of ideas in anesthesia is borrowed from aviation, and this is also another concept that, it's just if you liken anesthesia to a flight, if your intubation is your takeoff and your maintenance phase is your autopilot, your descent and landing is your extubation. What do the pilots do? So we have a lot to learn from them. What they do is maintain what we call a sterile cockpit. No noise, no nonsense, no unnecessary talk, and very effective lines of communication of who is in charge, whose role is what. So that is something as anesthesiologists we should really look at adopting, and we should indeed adopt. It's as much non-technical skills as it is technical, because the problems are finite. It is nothing that we are not aware of. And often the cause of problems is our inattention or not giving it enough respect that it deserves. Again, talking of respect, every paralyzed patient, one of the earlier speakers I saw, I think Dr. Venu in the next hall mentioned that the recommendations are that anyone who's got a paralysis should actually have their train of force measured objectively. Otherwise, we can't just rely on subjective opinions and think that, this patient is reversed. So we have to learn to treat our paralyzed kids or adults, for that matter, with the respect they deserve. And remember, extubation, whatever your intubation might have been like, your extubation is an elective procedure. So to that extent, you have actually much more control on things, and we should actually plan for failure. And if you don't plan for failure, you will encounter failure. So as anesthetists, we love the ABCD approach for everything. So I thought this is an easy way to look at an extubation checklist, a mental checklist, if you may. You just first think about it from an airway point of view. Is my patient able to is my baby able to protect their airway? Have I suctioned under direct vision? So you just see what you suck. Don't go around suctioning, and suction deep. You also look at avoiding airway trauma, obviously, that's self-explanatory, and think about, does this kid have a propensity towards obstructing their airway? Do they need a nasopharyngeal airway electively? So these thoughts you can have prior to the act of pulling the tube out. Just like for intubation, you pre-oxygenate for extubation, okay? And this is something many of us do as routine practice. But again, there are two views about it. Some pre-oxygenate to 100%, others pre-oxygenate. I personally pre-oxygenate to about 80%, which I still feel that when you don't have you still have some nitrogen splinting of the airways, which gives you a better FRC, and probably and you're still giving 4 times as much oxygen as the kid would have otherwise breathed. Also have to check, especially in small kids and babies, is the ventilation adequate? Don't allow the CO2 to build up and up and up, because CO2 itself is a potent, it's a excellent way of producing anesthesia and narcosis. So you have to have them at virtually physiological pH and physiological PCO2 to be able to pull that tube out and assess whether the breathing pattern is normal. Then moving to circulation, make sure they're warm, well perfused, and they're not really in hypotension, and you're not rushing fluids in as you're trying to extubate, because it takes time for the lung water to equilibrate through the various compartments that we just spoke about. Make sure the kid is well analgesed, because a kid in pain is going to cause you much trouble, and also confirm reversibility, confirm reversal of your neuromuscular blockade. None of this is rocket science, but these are the things. This is just a mental checklist that we can adopt ourselves. And then everything else. Again, warm kid. This is, again, one of the problems. Most of the time, we don't look at temperature, we don't measure it actively enough, and we don't do enough about it. So a cold kid is going to give you trouble. And also look at what team you have at your disposal, because when it all goes belly up, you need more people to help you. It's not a one-man or one-woman show. So there are largely 3 types of extubations that we can think about. I will leave deep extubation and Bailey's maneuver as more art than science. I'm not an artist. I don't think most of us here are artists. So as people of science, let us stick to the simple technique of no-touch extubations, okay? What we try to do at the end is increase your FiO2 to a reasonable number. 100% sounds absolutely fine. Make sure you have done your suctioning deep. You switch off your volatile anesthetic and allow time. Time is your friend. And Aruna madam was one of our anesthesia professors here when I learned, and she would always say, let the kid earn their extubation. Every child has to earn its extubation. And wait, time is your best ally. Okay, and so do not stimulate, do not allow others to stimulate. Your nurses are trying to be helpful, trying to put on the dressing of the kid and trying to take off the cautery plate as the MAC is reaching 0.3 and 0.4, and that is when the coughing and bucking happens. So it's a sterile cockpit, it's a no-touch zone. And this is generally the best way to do it in pediatrics. So what is laryngospasm? Despite our best efforts, laryngospasm can and will occur. If there are 1,200 delegates attending this conference, even at 1.2%, about 12 of us are going to encounter laryngospasm the next time we anesthetize a kid. So we have to be prepared, okay? So what it is the body trying to shut itself off and protect itself against pulmonary aspiration, if you view it teleologically. What is happening is, again, the glottic closure, either by the true cords adducting or in conjunction with the false vocal cords, in which case it becomes even harder to open up the airway. There are 3 mechanisms, as we know. There is an inspiratory stridor to it, there is an expiratory stridor, and a ball valve obstruction, which is the most dangerous component of it all. Like any reflex, it has an afferent, a center, and an efferent. The afferents are from the specific receptors, cold and pressure receptors, and something trickling down the laryngeal inlet, which provokes the superior laryngeal nerve to send signals to the nucleus tractus solitarius, from where, via the recurrent, both of these, as you know, are branches of the vagus, results in that dreaded scene that we don't want to see. That is not a scene any of us want to encounter, but we do from time to time. So what happens is the lateral cricoarytenoids go into spasm, then the thyroarytenoids, and also the cricothyroid muscles. So all of this may be parasympathetic, but the stress it causes to us is very much a sympathetic one, because there's nothing parasympathetic about the stress this causes. So is it possible to risk stratify? Of course it is, and we do it. Just a pointer to especially the postgraduates. The younger the baby, the more risk of having laryngospasm. Those with a recent URTI have an increased propensity to airway irritability for the next 6 to 7 weeks. Passive history of smoke. This is something that can be elicited. Any family members smoking, especially the father or mother, why not? It's all gender equal now. So it's a question that deserves to be asked as well. Insufficient depth of anesthesia and the experience of the anesthetist matters. So the apricot study actually came up with a very interesting number. Every 1 year of experience an anesthetist has in a pediatric specific setup, their incidence of bronchospasm and laryngospasm comes down by 1%. So someone who's been doing pediatric anesthesia for about 10 or 15 years, doing it well and paying attention, probably has a 10 to 15% lesser chance of provoking a problem at the end of the anesthetic. And again, intravenous techniques are supposed to be better than inhalational, but that is still a nascent stage. TIVA in adults alone in India is at a nascent stage. In fact, we just did a workshop the other day on it, but that is something that's worth thinking about. And some surgeries, understandably, it's a no-brainer that airway surgeries are more likely to cause problems. Surprisingly, hypospadias and skin transplants are known with increased risk of laryngospasms, and also urgent surgeries as opposed to elective ones. It is largely a clinical diagnosis. So we look at suprasternal retractions, supraclavicular retractions, paradoxical movements, and a tracheal tug. All of these sound great and great to write in an exam, but not all of these will see. In fact, 3 out of 4 of these will probably present typically, but the other 1 in 4 will just present for the first time with a desaturation and something not feeling quite right. Okay? So the inspiratory stridor, if heard, is terrifying, but not hearing it inspiratory stridor is ominous. So a silent chest is ominous. Please think about that as well. And eventually it all leads into a desaturation, a dreaded bradycardia, which cannot be compensated by our tachycardia, unfortunately, and cyanosis. So with that in mind, how do we go about preventing? Preventing is much better than trying to cure it. Risk stratification is key. And airway management only at appropriate depth. So typically stage 3, plane 2, and no sooner. Either at the beginning of your case or at the end of the case, do not mess with the airway at the wrong plane of anesthesia. And in fact, inhalational, although this is strictly not an extubation problem, an inhalational induction by the occasional pediatric anesthetist is significantly associated with higher risk than one who does it all the time. So in your hands, the technique that works best for you is the technique of choice, not something that just a book says. In the maintenance phase, again, there's emerging evidence that TIVA is a great option. And this large study by Angan Sternberg et al. That was published a good 12, 13 years ago now, showed that propofol had a much, much lower incidence of causing laryngospasm at the end of the case than the standard inhalational anesthetic, which is SIVO. DES, because of its airway irritability, those of who you use DES know that, it's associated with a higher incidence than either SIVO or isoflurane, which are excellent bronchodilators. And again, we have to ensure a well-analgesied child and good depth of anesthesia. I'll try and be sharpish from this point on. In the emergence phase, bottom line is if it's an LMA you have put in, it's probably a good idea to suction and take it out deep. If it's an ET tube that you have put in, wait for the child to wake up fully and keep a positive transglottic pressure throughout till extubation. Do not let the child breathe through on a spontaneous mode with an ET tube. It's like breathing through a straw. It never works well. Okay? And the no-touch technique that I was alluding to. Drugs-wise, you could try magnesium. Gulhas et al. Gave 15 mg per kg in their cohort and saw absolutely no laryngospasm as opposed to 25% in the placebo group. And this another study, both Turkish studies, both have looked at differing doses of magnesium between 15 and 30 mg per kg and found good evidence to support that, and I personally use magnesium 15 mg per kg in all my kids. Lignocaine has been tried to the point where they've done meta-analysis, and there's been statistically significant reduction with lignocaine, either which route you give it by does not seem to matter, but what seems to matter is you need to give it about 5 minutes before intended extubation. We know what to do. I'll just breeze on. So remove your triggering factors. Try and keep your larynx clear. Remove any supraglottic component through a triple airway maneuver. And CPAP. CPAP is your ally. So we know at this point we do not have a patent airway, so inhalational options are of limited value, which basically leaves you with intravenous options. Propofol is the most well-studied of all. A subhypnotic dose of about 0.5 mg per kg works in 3 out of 4 kids. If propofol doesn't, scoline is where you go to. That remains the gold standard. No less than 0.5 mg per kg. Okay? And if you do not have intravenous access, you're in trouble, but you have the only option you then have is giving a bigger dose of scoline and hoping that it works. And if you're giving intravenous suxamethonium, especially in the setting of a perioperative hypoxia, always premedicate with atropine because the bradycardia will almost certainly ensue. And managing a laryngospasm crisis, because that's what it is not just about knowledge, but also about your non-technical skills of team working. And because we encounter this as a team, you need to train to deal with it as a team. Okay, and this is a study. This is quite interesting. I just looked at how well in India we don't have any data, but this is a large French study of 107 tertiary pediatric anesthetists, and even there, it showed that there's no real structure to what they're doing. Most are working in a state of panic, trying to do what they can, but they don't have a structured algorithm. Most of them have differences in the way they try to combat it. Some use a face mask, some use CPAP. And again, huge variability of doses. So this is not good, because in a crisis, the last thing you want to be doing is trying to think. So because of this, we have tried to develop a local algorithm in our hospital, because what I believe is that it produces consistency and reproducibility. And because of that, we try to train together and simulate and train as a team, because you're not going to encounter this alone. This is one at Sakra, in the interest of time, where I work. This is the thing we give out to all our postgraduates and all our SRs, and there's a series of handouts like this for different situations that we encounter, and there's nothing more scary than a pediatric extubation. So this kind of lies available in the department for people to have a look at. So I'll conclude by saying that to be forewarned is forearmed. Every difficult intubation you have done is also a difficult extubation, so please treat it with the same respect. The bottom line is, if you have put an LMA, try to extubate deep and position the child appropriately with a patent airway. If it's an intubated kid, completely awake, and once the muscle relaxant has worn off. And if, God forbid, laryngospasm happens, and sooner or later, unfortunately, it's the reality of life, it will, CPAP, propofol, and scoline in that order. And I cannot stress enough that we encounter this as a team, so to deal with it, we need to train as a team. Thank you.